Right. So my presentation is knowing the Contoura machine, and I've made this presentation at the very basic level. And probably Contoura is the machine you want to invest on if you are looking to buy a machine at this moment. So basically, Contoura is not a machine. Contoura is a type of refractive treatment, which can be done on an Alcon machine. So what is Contoura? Contoura is basically a topo-guided LASIK treatment which is being done on a visual axis. So basically for Contoura you need two machines. First is the excimer laser where you will be doing the LASIK treatment, and then you need a variotopolizer which would basically pick up the data for the Contoura treatment. So essentially Contoura treatment comprises of two machines. First one is a topolizer vario diagnostic device, and then is the EX500 excimer laser system by Alcon. So what is happening? The first step is to take the diagnostic data on the topolizer, and topolizer is basically giving you topographic maps and HOAs. It's giving you the pupillometry, the K and Q values, the visual axis of the patient, angle kappa, and registration information for further cyclotorsions. And then from this topolizer, the information goes to a planning station where you design the Contoura treatment, which is then forwarded to the machine where the treatment is carried out. Now, EX500, again, one of the most advanced machines and the most popular machine around the world, and lightning fast ablation, so it is 1.4 seconds per diopter with a 500 hertz repetition rate. So this helps reduce the potential for stromal dehydration, which we know is very important when we are looking at bullseye results, flap shrinkage, and reduced patient fixation time, so the patient is very comfortable, and reduce patient's fatigue. And with a 1050 hertz 6-dimensional eye tracker, the tracking latency is 2 milliseconds, so it's a super fast tracker with the dynamic pupil tracking from 1.5 millimeter to 8 millimeter with active pupil centroid shift correction and compensation for angle kappa. Cyclotorsion in the Contoura machine is again very advanced. It is taking care of static and dynamic cyclotorsion. So static cyclotorsion basically means when the patient is going from supine to basically lying down to getting up, there is a cyclotorsion component which is compensated. Plus during the surgery, if the patient is torting, there is a dynamic cyclotorsion which is again being compensated in the Contoura machine. Then the short distribution in Contoura machine is a special kind of a short distribution where there are no overlapping shots. The overlapping shot is basically after the fourth shot, the fifth shot is basically overlapping. So that takes care of the thermal shot distribution as well. So due to high pulse frequency, there is of course a theoretical risk of thermal effects. And with the wavelight system, which is the Contoura system, this prevents it by allowing every fifth pulse to overlap with the previous one. And then of course there's optimal temporal and spatial shot distribution required to minimize the potential thermal load. And then of course other features like enhanced beam path, so completely sealed beam path and continuous nitrogen flushed beam path with onboard nitrogen generator, and this basically helps to along the laser life of the expectancy of the laser head. And then of course other features include the integrated heads-up display, the slit projector which is very useful, and the increased working distance of 25 centimeters and the built-in non-contact pachymetry. And plus, of course, with other kind of laser machines, you have variety of treatments available. So you can do the wavefront optimized treatment, the wavefront guided treatment, the topography guided, of course, what we are discussing on. So you can do Contoura, which is the topolizer guided, and you have an oculizer guided treatment as well. And then, of course, you can do custom Q asphericity guided and transepithelial PRK, which they call it Streamlight. And we have done almost 50,000 Contoura procedures as of now, and we've never been happier with the results. So thank you so much.
I have one small question. What are the indications for Contoura as such, and how it is different from the routine refractive procedures?
So actually, we don't have any indications as such. We are basically relying on the quality of maps. If we see the maps are good, then we proceed with the Contoura treatment. If we feel the maps are not very good to do the treatment, then we prefer to shift it to a wavefront optimized treatment.
So here in Contoura, you're treating the topography and the refractive error. Right?
Yes.
So suppose you have a high corneal cylinder, and you're on refraction you find that the cylinder is less. That means there is a lenticular astigmatism,
Yes.
which normally the lenticular astigmatism compensates for the corneal astigmatism. So when you treat the cornea based on the topolizer, then you will have a residual lenticular astigmatism. So how do you manage this?
So how much is the difference that we're talking about?
You can have up till 2 diopters of difference.
No, I
I've
would-
seen-
I would not
I will
go-
show you a case.
I would not
I
go
will
ahead.
show you a case. I showed it to John Canelopoulos also. His answer was yes, if there is lenticular astigmatism, then it comes down over a period of time. But this is only a hypothesis. And that means until it comes down, the patient is unhappy because he's got like a 1.5 or 2 cylinder.
So I would not go ahead with the Contoura treatment.
Exactly.
So, see, normally in all cases, if you see, there is some amount of lenticular astigmatism which compensates for the corneal astigmatism. So that is there. And if you treat only the corneal astigmatism, then you may have a residual astigmatism in the opposite meridian. So this is what is there. So that is what is my apprehension about the Contoura.
Again, the same question. Basically, it all started with topo-guided treatment, treating for corneal abnormalities. And suddenly it came as a refractive procedure. So I was quite taken aback about it. So I would like your comment on that part.
See, most machines have topo-link treatments. So it's nothing new. I think Alcon basically has used it very successfully for marketing the Contoura. But in refractive surgery, I believe you have to treat the refraction primarily. Unless there is an abnormality either in the ocular wavefront or the corneal wavefront, in which case you may need a topo-link or a wavefront guided treatment. Otherwise, see, for example, in phakic IOLs, you get excellent results. Actually, your results may be better in phakic IOLs. The best
At
corrected
times,
vision will be
in
better.
high cylinders, I would.
Yes, it will be better. Why is this? It doesn't treat the cornea or it doesn't treat the wavefront. It's treating the refraction. It's just because it's closer to the nodal point, you get a little bit of magnification, so the vision is better. So even if you treat the refraction, suppose the patient is 6'5" or 6'4" or even 6'6", why would you want to do a customized treatment? In fact, if you have a proper figure and the ready-made clothes fit, why would you want to go to a tailor? You can just pick it up off the shelf and wear it, right? It's only those who have maybe one arm is long or one shoulder is drooping, then they need the measurements and customized fitting, otherwise they won't look good with a